Hello, I talk about a randomized trial of intrapartum fetal ECG segment analysis. I study Catholic University Nursing School. My name is Joscelyne and my teacher is Master John Moscoso. Definition: what for severe intrafetal ECG? The main objective of intrapartum surveillance is to decrease rate of fetal and maternal morbidity and mortality. With intrapartum fetal surveillance should be able to detect fetus at risk, to implement measures intended to improve perinatal outcome.
Welcome to Electronic Fetal Heart Rate Monitoring, Definitions, Interpretation, and Management, an interactive educational program created by David A. Miller and Frank C. Miller in conjunction with General Electric Healthcare. This educational program is designed to review and reinforce the standardized fetal heart rate monitoring definitions proposed by the National Institute of Child Health and Human Development in 1997 and 2008, and endorsed by the American College of Obstetricians and Gynecologists, the Association of Women's Health Obstetric and Neonatal Nurses, and the American College of Nurse Midwives. In addition, the program introduces a comprehensive, systematic, evidence-based approach to standardized fetal heart rate interpretation and management that reflects consensus in the medical literature, is practical, and most importantly, teachable. The objective of intrapartum fetal heart rate monitoring is to optimize outcomes for mother and baby. This is best achieved by practicing according to the standard of care. In other words, by providing care that is reasonable and careful. This determination is made on the basis of credibility, which in turn requires the care provider to be factually accurate and to be able to articulate a thoughtful plan. During this course, reinforcement of standardized definitions and interpretation of fetal heart rate tracings provides the tools necessary to ensure factual accuracy. And a practical, systematic approach to standardized fetal heart rate management provides a framework that will allow you to articulate a comprehensive, thoughtful, reasonable plan. By the end of this course, participants should be confident that they're able to provide information regarding fetal heart rate monitoring to their patients and peers that is factually accurate and articulate. Since 1997, important consensus publications have reshaped the landscape, making fetal heart rate monitoring simpler and more practical than it has ever been. Throughout this course, we will review these key publications and describe their contributions to the standardization and simplification of intrapartum fetal heart rate monitoring.
Application in medicine. A meta-analysis of several randomized clinical trials. It is concluded that the analysis of ST segment serious neonatal acidosis decreased the number of PH intrapartum made and operative deliveries. We conclude that it is a useful method of fetal surveillance to FCF inquired one.
If you're still pregnant, you probably can't wait to have your baby already.
Relax. There's a very good chance that you'll go into labor at any time in a natural way during this, your 41st week. If you don't, your practitioner may talk to you about inducing labor. Although about 5% of pregnancies extend 3 or more weeks past the due date, most doctors won't let pregnancies last this long. That's because a prolonged postdates pregnancy and labor can lead to an increased risk of complications for both mother and baby. Babies born a bit later may have dry, almost parchment-like skin and may be quite overweight. In fact, even now, at your 41st week, your baby is 20 inches long and about 8 pounds in weight. He's a big boy, or she's a big girl, and that baby is very, very ready to meet you.
Pro. a decrease in neonatal seizures without affecting rate of perinatal mortality, and aspects of increased operative delivery. Cons. The downside of this process is that some women do not know about this process and not go to the doctor for these tests. Either they cannot by economic problem or lack of information.
Fetal monitoring may be used at different times during your pregnancy and during labor to assess your baby's well-being. The fetal monitor uses ultrasonic waves to pick up your baby's heartbeat. This is converted to a heart rate, which is displayed as a number on the left side of the monitor and recorded as a variable line on the graph paper. The fetal monitor can also be used to monitor the frequency and duration of your contractions, but not the strength of the contraction. The contraction will be displayed as a wave or hill pattern on the graph paper and on the large screen above the monitor. Your nurse will place two soft, stretchy Velcro straps around your abdomen to hold the two transducers in place. Ultrasound gel will be applied to the transducer, which is placed on your lower abdomen to pick up the baby's heartbeat. This works in a similar way to the Doppler used in your doctor's office. It's not uncommon for the nurse to have to adjust the placement of this transducer during monitoring as the baby moves around. The second transducer, which is called a toco transducer, is pressure sensitive and will be placed on your upper abdomen to record the contractions. If you are having twins, you will have two transducers to pick up the baby's heart rates and one to record your contractions. The second heart rate will appear in the center on the monitor. The non-stress test is used to assess your baby's well-being by monitoring your baby's heart rate while you are resting and the baby is not being stressed by contractions. Your nurse will connect you to the monitor and record the baby's heart rate for about 20 to 40 minutes. A reactive or normal test will show that the baby's heart rate has variability within a normal range. A non-reactive test may indicate that the baby has health issues which need to be further assessed. When you are admitted in labor, your nurse will use the external fetal monitor to check your baby's heart rate and your contractions. After an initial period of monitoring, you can be disconnected from the monitor to walk or use other comfort measures. Your nurse will periodically reconnect you to the monitor to check your baby's heart rate, but you do not need to remain in bed for these checks. The monitor cords are long enough for you to walk around the bed or sit in the chair. If you are induced, if you receive medication to augment your labor, or if you receive an epidural for pain management, your baby will need to be monitored continuously until delivery. Epidural patients will also need to remain in bed.
Issue up in Ecuador. In Ecuador and other countries, if this fetal monitoring continues as they have, the product suffers no managed or injuries as hypoxia. Conclusion: the idea that birth control modernization should improve the neonatal outcome has prompted fetal monitoring. Using fetal monitoring is to recognize situations of fetal hypoxia during the birthing process, with the intention to intervene and prevent fetal damage.
Prior to the 1970s, the only monitoring systems available to most women in labor were the nurse's eyes, ears, and hands. As time passed, advances in external fetal monitoring devices developed, such as the fetoscope and the Doppler. Advanced internal monitoring devices were also developed for high-risk pregnancies. The current monitoring technology used every day in this country by labor and delivery nurses is electronic fetal monitoring, or EFM. Nurses who use electronic fetal monitoring need to understand and recognize fetal heart rate patterns, beat-to-beat variability, and uterine activity, and should use accepted terms to describe these patterns. It is especially important to document reassuring and non-reassuring changes in heart rate patterns, as well as the fetal response to actions taken to treat the non-reassuring changes. And it is important that the nurse documents uterine activity.
Thank you for your attention.